Oral lesions in HIV. So yesterday we discussed about the clinical features, pathogenesis, structure of HIV. Structure I did not go in detail because you don't really have to know the structure in detail, because this is oral pathology and we mainly deal with the pathology. So yeah, but what you need to know is it is a retrovirus, it is sacrahedral, and it has an envelope and a protein. Okay, so GP120 and GP41 are the two main proteins. Then you have to know how it is transmitted. So mode of transmission is something that you have to know. Then pathogenesis is also discussed yesterday. So there are two major targets of HIV: immune system and CNS. All this is been done. Okay, then how it is targeting, what it is targeting, how it is transcribed from DNA to the full length RNA by the host. So basically what happens is the virus, the protein of the virus attaches to the CD4 cells, and there the viral gets uncoated, that is, it gets internalized, and that viral RNA is reverse transcribed onto the viral DNA. Then the cytoplasm of infected cells is transferred into the cytoplasm of the infected cells by reverse transcriptase. Okay, then after it gets circularized, it gets integrated into the host cell's DNA, and the DNA is then transcribed into the RNA by the host cell. So basically, if I write it in one line, the virus attacks the CD4 cells. Okay, then the CD4 cells, if you have to be specific, you have to mention that it attacks the DNA, or sorry, not the DNA, it attacks the protein. Basically it attacks the cell surface of CD4 cells. You do not have to go in detail. So virus attacks the CD4 cells. After attacking the CD4 cells, it replicates, or it reverse transcribes the linear viral DNA into the cytoplasm of the infected cells. Okay, so virus is going to attack your CD4 cells, and in that it is going to become, as soon as it enters the infected cell, it becomes uncoated, and the DNA of the virus is exposed, and then it is reverse transcribed on to the host cell. So the integrated DNA is transcribed full length RNA by the host cell. So once the DNA is infected by reverse transcriptase, that DNA eventually starts multiplying in the whole body by the host cell itself. Okay, then you have RNA is, then again DNA is transcribed. In a similar way, RNA is also transcribed. Okay, it is either packed with particles in severe genome for progeny, and that results in widespread dissemination. So I'll show you a picture to understand it better. So this is the pathogenesis of HIV. So this is the HIV virus, which is going and attacking your CD4 cell. It is fusing with the CD4 cells, where it is getting uncoated first, then it is getting reverse transcripted, and then the nuclear material is transported and transcribed. After that, the RNA is exported, translation occurs, and then your budding also occurs. So you do not need to know this depth, you just need to know that the cell, viral cell is attacking, and it is attacking CD4 cells, and this after attacking, it gets uncoated and then it reverse transcribes itself. Okay, so that is enough. So you can refer to this picture as well, that there is binding, there is a virus which is binding, and after binding it is getting uncoated and it is getting reverse transcribed. Okay, and once it is getting reverse transcribed, it is getting integrated into the host cell, and so it is spreading to the other cells in a similar pattern. Okay, so that is about the pathogenesis. So it has a very lymphatic kind of spread, and if it enters the circulatory system, it results in a widespread dissemination to the brain as well. This infection is primary HIV. Okay, so coming to the clinical features, we discussed these clinical features in the part 1 video, acute retrohedral syndrome. Now what is this? This is a type of a clinical symptom which comes with fever, fatigue, headache, weight loss, depression, GI distress, pharyngitis, and it eventually decreases. Okay, but what you need to know is it develops from 1 to 6 weeks after the exposure. Okay, so once the virus is exposed, it is giving these symptoms in 1 to 6 weeks post the exposure. Then you have something called as a latency period or the window period, where after this prolonged symptom, like an episode of prolonged symptoms, those symptoms rapidly stop. So there might be two possibilities, that the primary symptoms might progress and become severe, or there might be latency, right? So this is again rare, and latency is something which is very common. Okay, this primary clinical diseases can also be rapidly progressed to cause complications. Okay, then coming to the latency stage or the window period, where so in the window period what happens is the immune response is generated, that is your cell mediated immunity is generated and humoral immunity is generated. Then your CD4 cells count becomes normal. Okay, because of viremia. Viremia is a kind of a specific immune response against virus, so results in a viremia drops down. So basically viremia is the virus infection that we're talking about, that comes down. Okay, because of this cell mediated immunity, and CD4 cell count becomes normal. Okay, that is period of latency. Then after that comes the period of seroconversion, where within 6 to 12 hours antibodies of HIV are detectable in blood through ELISA and Western blot. So Western blot and ELISA are two diagnostic tests which are done, where the serology tests show positive for HIV. Okay, this is usually after 6 to 12 weeks post an infection. Now patients at that time are confirmed as HIV positive, as I told you. Now what occurs after this are your, I'll just mention here majorly secondary symptoms, right, or secondary HIV or secondary clinical manifestations or clinical features, right? Now we will see what these are. So your secondary symptoms include a primary, so as a result of HIV infection in lymph nodes, infected people who are otherwise asymptomatic develop lymphadenopathy. Okay, usually the secondary symptoms are not very pronounced, the latency symptoms are not very pronounced, but you can see lymphadenopathy. Okay, then so basically this is your resting phase, I'm so sorry for this. This is your resting phase, that is your latency period. After this, in latency period, the only thing you can exclusively see is your lymphadenopathy. Okay, this is the only thing that you can see in the latency period, right, which is almost a duration of 3 months. So first to 6 weeks, let me just find a white page and write. Okay, so yeah, I'm going to write here. So first few weeks, that is first to 6th week, you have your primary HIV, where you have primary clinical manifestations, right? Then comes your 6th to 12th week. So basically after this 6th to 12th week, so in this your after the 6th week, from the 12th week onwards, you see something called as the latency period. Okay, this period is nothing but the period of arrest. Okay, we don't use the word arrest because there is nothing that is getting arrested, but you have your immune response. That's why we call it a latency period. Now this latency period lasts for up to 3 months. Okay, now after this is your secondary infection, right? So this is the weekly flowchart that you need to remember. Okay, so yes, where were we? This is all done. Yeah, so that was about the infection in weeks. Now coming to the symptomatic. So we dealt asymptomatic, we dealt with primary symptomatic, then asymptomatic, and now again symptomatic. So what is happening in symptomatic HIV infection? Now the weeks that I told you could vary from case to case or person to person, because it is not a fixed duration. Okay, but it is considered because it occurs in majority of cases. Okay, now coming to the symptomatic HIV. So after a variable period of clinical latency, see here also I have written a variable period of clinical latency. Okay, after a variable clinical period of latency, the patient eventually develops constitutional symptoms. Constitutional symptoms are your secondary symptoms, that is diarrhea, weight loss, chronic fever, oral candidiasis, herpes zoster, ordinary leukoplakia, mild opportunistic infections. Okay, so diarrhea, weight loss, chronic fever, oral candidiasis, herpes zoster, leukoplakia, and mild opportunistic infections. Okay, now coming to AIDS. AIDS is gradually, now this was something that we dealt yesterday. Okay, so a long run symptom which is seen in symptomatic patients, that is usually after a secondary response, that is your diarrhea, weight loss, chronic fever, and all the opportunistic infections. Okay, now coming to the AIDS, it is gradually patient moves towards advanced stage. Now this is again in secondary stage and advanced stage. What happens in this advanced stage is that there is a gradual movement, okay, and of the bacteria towards suppressing the immunity, and you have opportunistic infections in this period, and there is a high viral load on the blood, and the lymphoid tissue is totally destroyed. Okay, so malignancies could come in a play, infections, opportunistic infections could increase in number. There are a lot of things that could occur because of this. Now, the something that we left yesterday which was important is the oral lesions, and it has been asked as a 10 marker. So let's see that. Before that, there is the CD4 cell count. So basically, initially the CD4 cell count is 500. Okay, that is in asymptomatic stage. Then in symptomatic, the count gradually increases. Then in AIDS, that is your secondary symptoms, it then decreases, and when it is opportunistic, it again decreases. So basically the graph is falling down. Okay, now not exactly, so it basically goes down, up, and again down. So okay, so coming to this table is not really important, you can skip it. Coming to the oral lesions. Okay, so what are the oral lesions? Let us see. So Clearinghouse classified the oral manifestations of HIV in group 1, 2, 3. Okay, so in group 1, which are strongly associated as in they are definitely associated with HIV infection, that is Candidiasis, hairy leukoplakia, Kaposi sarcoma, Non-Hodgkin lymphoma, and periodontal diseases. So Candidiasis we will read in detail and see what this is about. So we have strongly associated HIV infections, that is Candidiasis, erythematous pseudomembranous angular cheilitis that occurs in this hairy leukoplakia, Kaposi sarcoma, non-Hodgkin lymphoma, and periodontal diseases. Coming to the second one, that is less commonly associated HIV infections. First is the bacterial infections. So bacterial infections are Mycobacterium ovium, that is your intracellular Mycobacterium tuberculosis. So basically these are the bacterial infections which are opportunistic or which could develop because of HIV. So TB is one such example. Then you have melonic, what is this? Melonic hyperpigmentation. Melonic hyperpigmentation, that is your melanin producing cells, melanocyte hyperpigmentation. So then you have necrotizing ulcerative stomatitis, salivary gland diseases, that is your dry mouth, unilateral or bilateral swellings of the major salivary glands, thrombocytopenia purpura, oral ulcerations, viral infection, herpes simplex, varicella zoster. Then third one is your HIV seen in HIV infections. So basically these are seen but cannot be strongly associated that this is because of HIV. So actinomycosis caused by actinomycosis israeli, this could be opportunistic infection again, E. coli, Klebsiella. Then your cat scratch disease, this is also an opportunistic infection. Epithelioid angiomatosis, drug reactions, okay, ulcerative erythematous multiforme, and fungal infections, that is your cryptococcus, neoformans, and asparagus. So that is your opportunistic infections. Neurological disturbances could also be a cause, that because of the septicemia you could have neurological disturbances. Then there is recurrent aphthous stomatitis followed by something called as viral infections, that is other viral infections. Okay. Then coming to oral candidiasis, it is the most common intraoral opportunistic infection of the fungal origin associated with an HIV infection. Oral or esophageal candidiasis is predictive for subsequent development of a full-blown AIDS in untreated patients within 2 years. So if a person has a lot of oral and esophageal candidiasis, then not only on the basis of this, but this could be a major diagnostic cause of your AIDS. Okay, diagnostic feature. Okay, not a cause, diagnostic feature. This could be an aid feature, like a helpful feature, but it cannot be a sole diagnostic tool. Okay. Then coming to the clinical patterns, there is pseudomembranous candidiasis, which is noted when CD cell 4 count comes down. Then you have your appearance, that is white to yellowish white plaques. Okay, so pseudomembranous candidiasis is seen when noted when CD T cell count is below 200, so less than 200 cells per micro. Okay, 200. So cells which are seen are noted when the cell, so basically this pseudomembranous candidiasis is seen when the CD4 cell count is below 200. Okay, the appearance is white to yellowish white plaques, easily scrapable, and which expose the red areas. Now location, lesions are extensive, involving more than one site in the oral cavity. It also extends to involve the oropharynx and esophagus. Okay. Now coming to the erythematous candidiasis, it begins to appear when CD4 cell count is below 400. So you see pseudomembranous candidiasis was when it is below 200, and erythematous candidiasis is when the CD count is below 400. Okay. So what happens in this is the lesion appears red in color. It occurs in the dorsum of the tongue and buccal mucosa, like how it occurred here in more than one site in the oral cavity, and oropharynx, esophagus. Here it is in the dorsum of the tongue, palate, and buccal mucosa. Okay, so tongue, this is your tongue, palate, and buccal mucosa. Okay, tongue, palate, and buccal mucosa. Then so basically in tongue you see central papillary atrophy. Now hyperplastic candidiasis. What is hyperplastic candidiasis? Appearance of white plaques cannot be removed by scraping. Okay, hyperplastic candidiasis is white plaques that cannot be removed by scraping. Then you have angular cheilitis or erythema or fissuring or scaling of angular mouth. So basically there are cuts in the ends of the lips where the two lips meet. Okay, so the angle of the mouth, you have angular cheilitis. That is also a type of opportunistic infection. So diagnosis is, it stands for PAS, that is candidal hyphae, and biopsied tissue or smears from the lesion, culturing the organism on sabrod agar. Okay, so that is about angular cheilitis, where the diagnosis is done via a stain, that is PAS stain, for a fungal infection called candidal hyphae. Then coming to the treatment of this, it is topical, systemic treatment. Topical includes clotrimazole, that is an antifungal topical cream. Okay, antifungal topical cream, or you have systemic, you have fluconazole tablets or intraconazole. Cotrimoxazole also has there is a substitution for this, that could be a fluconazole or intraconazole, and you have something called as antifungal therapy. Then coming to oral hairy leukoplakia, so this is the third clinical manifestation which is usually seen in the oral cavity. Okay, there are few too many, we will go a little quickly in this one. Okay, so you have something called as oral hairy leukoplakia, which was most commonly associated with Epstein-Barr virus. Okay, and it is common in patients with AIDS. Yeah, so oral hairy leukoplakia. Oral hairy leukoplakia is the most common Epstein-Barr virus related leukoplakia, which is occurring due to a virus called Epstein-Barr virus, which is occurring in patients with AIDS. So Epstein-Barr virus is also associated with several forms of lymphomas in HIV. Clinical features include a range in appearance from faint to white vertical streaks. So you have white vertical streaks to thickened and followed areas of leukoplakia exhibiting shaggy keratotic patch. Okay, so in oral hairy leukoplakia, what is the first thing that you're going to write? It is caused by the EBV. Okay, so basically it's associated with patients in EBV viral kind of HIV. Then second is you're going to write that it is also associated with severe forms of lymphomas. So EBV is associated with lymphoma. Okay, you're going to write EBV. Oral hairy leukoplakia usually occurs in patients with EBV related virus, HIV. Okay, EBV virus related HIV, and it has several forms which is also related with lymphoma. Okay, so that is one thing. Then you have clinical features, that is there is a range in appearance from faint to vertical streaks. This is basically a shaggy patch of keratotic surface is there. Then it is seen in the lateral borders and lateral borders of the bilaterally tongue and floor of the mouth, buccal, mucosa, tonsillar region, soft palate, and posterior portion of the pharynx. Then if you see the histopathology of the hairy leukoplakia, so first one in the oral this thing was your oral candidiasis. The second one is the oral hairy leukoplakia. Okay, then coming to the histopathology of leukoplakia, you can see some acanthosis, and then you can see demonstrate surface corrugations and thin projections. So you see thin projections in the of the epithelium in the connective tissue. You see acantholysis and balloon cells, that is your Zank cells. Then there is nuclear beading, that is arrangement of nucleus in beads. Then extensive EB replication that displaces chromatin to the nuclear margin. Then you have something called candidal manifestations which are seen in EBV patients as well. Now treatment is OKC is usually oral candidal oral hairy leukoplakia is usually asymptomatic. Okay, so you do not require a treatment. Occasionally the soreness and discomfort is present. Occasionally the oral hairy leukoplakia has soreness, discomfort, and appearance of warrant treatment. Okay, then since many oral hairy leukoplakia cases reveal candida, they have something called as topical antifungal therapy, because people assume that it is oral candidiasis and give antifungal therapy. Okay, we have a lot to do. Then there is something called Kaposi sarcoma, where there is a multifocal neoplasm of the vascular endothelial in origin. Okay, multifocal neoplasm of the vascular endothelial. Okay, so this is basically a type, Kaposi sarcoma is a type of neoplasm. Okay, and it is vascular in origin, and so basically it is a type of sarcoma involving the blood vessels. Pathogenesis is human herpetic virus is involved. Human herpes virus, that is HSV. HHV, human herpes virus. Okay, now it is involved with sites is palate, gingiva, tongue, and oropharynx. Appearance is macular, nodular, or raised. Okay, this is the tongue. It is macular, nodular, or raised. Okay, then early diagnosis is it is flat, red, asymptomatic. Diagnosis is biopsy from lesion examined with Wharton starry stain. Okay, so what is the stain for diagnosis of oral hairy leukoplakia? Kaposi sarcoma is Wharton starry stain. Then coming to the next one, that is your non-Hodgkin lymphoma. This is also a type of oral manifestation which is seen. Non-Hodgkin's lymphoma is a type of malignancy of the lymphocytes. The non-Hodgkin's is a high grade and more aggressive one than the Hodgkin's. It has, for the types, there is Burkitt's lymphoma, anaplastic lymphoma, diffuse cell lymphoma, immunoplasmacytic lymphoma, primary effusion lymphoma, plasmablastic lymphoma, and then something called as extranodal, that is your CNS involved lymphomas. Okay, then the oral lesions of this non-Hodgkin lymphomas are gingiva, which occur on gingiva, palate, tongue, tonsil, maxillary sinus, intraosseously outside the periodontal attachment, and loosening of teeth occurs. There is widening of pedal and lamina dura in the radiograph. This is the diagnostic clue. Treatment is chemotherapy and radiation. Then periodontal lesions. Periodontal lesions of the HIV or AIDS are atypical patterns. They are periodontal diseases associated with HIV infection. Linear gingival erythema, non-plaque induced gingivitis, exhibits distant erythematous bands of marginal gingiva, diffused or punctured erythema of the attached gingiva. Okay, so there is non-plaque induced gingivitis which is exhibited. Okay, and there is erythematous band of marginal gingiva. Okay, and then there is diffused or punched erythema of the attached gingiva. Then, so first periodontal disease is about gingiva. The attached gingiva is affected, or the marginal gingiva is punched out and erythematous. Okay, then this is mainly non-plaque induced gingivitis. Then you have something called as NUG, necrotizing ulcerative gingivitis, refers to ulceration and necrosis of one or more interdental papillae. Okay, so the interdental papillae is affected in the NUG, that is your necrotizing ulcerative gingivitis. There is no loss of periodontal attachment. Okay, so no loss of periodontal attachment. The interproximal gingival necrosis is occurring. There is bleeding and halitosis. Okay, so NUG is a type of oral manifestation which is occurring in the gingiva. Okay, then you have something called as NUP, necrotizing ulcerative periodontitis. So the gingival ulcerations and necrosis associated with loss of periodontal attachment. So there is a loss of periodontal attachment, exposing alveolar bone. Now loss of adjacent alveolar bone, then necrotizing stomatitis. When necrosis extends beyond the periodontium, okay, the necrosis occurs beyond the periodontium, in periodontium, beyond the into the mucosa and the osseous tissue, that is your necrotizing stomatitis. So we got to know NUP and necrotizing stomatitis is when necrosis extends beyond the periodontium. Okay, then treatment for this is increased rate of attachment loss. Periodontitis is metronidazole is the drug of choice in antimicrobial therapy, and debridement, that is the removal of debris if any, and follow up. Okay, then there are mycobacteria, chlorhexidine mouthwash also should be prescribed in these patients. Okay, then there is mycobacterial lesions, that is infections of TB that is infecting the oral cavity as well, which is uncommon, but they do occur in less than 5% of individuals. There is ulcerations in the oral cavity and granular leukoplakia. Treatment could be triple regime, that is your TB treatment is given. Then there is hyperpigmentation of the oral mucosa, okay, usually seen in the oral mucosa, skin and nails. Causes: HIV infection itself is one cause. Then you have medications, that is ketoconazole and zidovudine. So this is again, this is antifungal, this is antiviral. Okay, so this is nothing but just a pigmentation which is manifested in HIV patients. Then coming to HIV associated salivary gland diseases, that could include a heterogeneous group of symptoms varying from person to person, and as HIV infection progresses in some individuals, these occur in about less than 5% of the HIV patients. The clinical signs include parotid enlargement. So parotid enlargement is a main sign. There is a bilateral parotid enlargement. Then you have pathogenesis is HIV progresses into the salivary glands. Then the salivary glands are infiltrated with CD8 lymphocytes, CD4, CD8, leading to diffuse infiltrative lymphocytosis syndrome, resulting in salivary gland enlargement. So there is something called lymphocytosis syndrome, because of which there is some salivary gland enlargement. What is lymphocytosis syndrome? Lymph nodes enlarge in size and lymphocytes, they enlarge in size and they spread to the nearby organs. So salivary gland enlargement is occurring. This group is at risk of B-cell lymphoma as well, because it is affecting lymph nodes here, right, and lymphocytes as well. So xerostomia could occur as a part of this disease progression. Then thrombocytopenia purpura, hematological disorder characterized by a number of circulating platelets, occur in HIV due to drug, malnutrition, immunological alteration, microbial invasion, or due to course of HIV diseases. So thrombocytopenia purpura is a hematological disorder. Okay, then coming to the hematological disorder is thrombocytopenia purpura. Then you have oral lesions in thrombocytopenia purpura as well, that is pinpoint petechiae, whatever you call, pinpoint, okay, pinhead, a pinpoint petechiae occurring in the oral cavity of thrombocytopenia purpura following a minor trauma, or even if there is any disturbance in the mastication. Then spontaneous gingival hemorrhage. Treatment is platelet transfusion, corticosteroid therapy. Then herpes simplex virus infection, HSV, could also be infective because of persistent activity of HSV for more than a month, it is one of the most accepted definitions of AIDS. So there is an activity of HSV infection. If there is an activity of HSV infection, it will definitely occur in these patients. Numerous pinhead vesicles collapse to form ulcers. We have already read HSV in detail, so we just have to mention a few points. Then herpes zoster. Herpes zoster is another type of a recurrent viral infection seen in HIV patients. The clinical cause is very severe morbidity, is usually in basically death. Death is seen in patients with herpes zoster, if it is severe. Then in AIDS, herpes zoster begins as a unilateral cluster of vesicles, subsequently beyond the dermatomal boundary, and then it heals by scarring. Okay, so then you have aphthous ulcers, which present as a recurrent round shallow painful ulcer, which is variable in size, found in the oral cavity, non-keratinized. Treatment is topical steroids. Contraindicated therapy is immune suppression. Okay, immune suppression is a contraindicated therapy. Then there is something called as oral squamous cell carcinoma, that is a malignancy which is seen in patients with HIV and AIDS associated with risk factors. Then you have molluscum contagiosum, infection of the skin caused by pox virus. It presents as a shiny white hemispherical skin colored dome shaped papule. Wow, so much of description. Tiny white hemispherical dome shaped capsule. Okay, tiny white hemispherical dome shaped capsule, okay, with a center depressed crater. Now in patients with AIDS, numerous lesions will be present with no tendency to undergo spontaneous resolution. Some grow to large size. Treatment is cryotherapy for this. Okay, cryotherapy is the treatment for pox virus. Then histoplasmosis, it is most common endemic respiratory or fungal infection. Okay, endemic respiratory fungal infection, and its signs include fever, weight loss, splenomegaly, and pulmonary infiltrations. Okay, then diagnosis is, now this is the overall diagnosis. I have spoken about this in the previous video as well, but briefly I'd like to tell you that PCR is a technique used. We use different type of PCRs, one for the DNA, one for the RNA. Those of you who don't know what PCR is, it is polymerase chain reaction test. Okay, so you check the polymerase chain reaction and give a diagnosis. So it can be detected as low as 20 copies, which is highly specific test. This is a highly specific test and it is sensitive. Okay, very useful for early diagnosis of HIV in usually newborns. Then limitation could be lost. It could be lost easily, but that's not a satisfactory limitation. So yeah, usually we prefer PCR itself. Then you have something called as antigen detection. So we detect the antigens in the window period of infection. Okay, in the window period of infection we detect the antibodies in the blood. When the virus is replicating, we can detect the antigens in the blood. That is usually in the window period. Yes, then this is non-sensitive test, and this is only positive in window period, not in primary period. ELISA is also done. Then you have Western blot technique.
Okay, here's Baiju.
So we spoke about the diagnostic test, that was your PCR. So now we are reading about ELISA. ELISA is also a diagnostic test, okay, and this is done for repeated testing, and it is sensitive, and it is 99% sensitivity. That is, it is a good tool for diagnosis, but it cannot help in early diagnosis sometimes, and it is showing negative in the window period, like your antigen test. Sorry, it is showing only positive. Oh yeah, it is showing negative in the window period, that is during the last phase of the infection. Okay, in the last phase of infection it shows negative, not during the window period. Okay, so during the window period and the last phase of infection, both it shows HIV positive. I'm so sorry guys. So it shows negative in the window period as well as the last phase of the infection. Coming to the advantages, it is cheap and easy to perform. ELISA is a mainstay for HIV diagnosis. Now coming to Western blot technique. What is Western blot technique? It detects specific antibodies and shows them as a separate band on the gel. So it shows, if it is positive, it shows bands like this, at least two bands if there are present, or three, it is a positive test, or if there is less than two bands or one band or no band, then it is negative. Okay, then coming to the interpretation, see, as I told you, 2 to 3 bands positive, no band negative. Then intermediate, if only one band is positive, then we have to repeat the test for 4 to 6 weeks until the band becomes either completely negative or completely positive. Limitation is negative during window period and sometimes in late phase of infection, and cannot be relied for early diagnosis. Immunological tests, CD4 cell count can be seen, CD4 cell percentage and ratio. Then you have your salivary tests, and in salivary test you check the saliva, that is the circulating fluid, by the immunoglobulin content and the antibodies captured in the saliva, that is IgG, that is formed against HIV. Okay. Then the treatment could be nucleoside reverse transcriptase inhibitor. So there is the pathogenesis, we studied that there is something called reverse transcriptase or reverse transcription that is occurring. So we are going to cut off the reverse transcriptase with a scissor like thing, that is your inhibitor. Okay, so nucleoside reverse transcriptase inhibitor, nucleotide reverse transcriptase inhibitor, non-nucleoside reverse transcriptase inhibitor, okay, and protease inhibitor. So for a few examples for nucleoside reverse transcriptase could be your abacavir, tenofovir, lamin-vidae, okay, adofovir, tenofovir is foir is adifovir, and tenofovir is examples for nucleotide reverse transcriptase inhibitors. Then protease inhibitors, fusion inhibitors, integrase inhibitors, and CCRS inhibitors. Then if there are any following treatments for the complications or clinical manifestations, those will be dealt individually, as that I have discussed already, like each treatment, right? Now that's all for HIV. HIV is a very very long topic, so I had to cover it in 2 videos, that is part 1 and part 2. Okay, so part 1 wasn't that in detail as part 2, but part 2 is very important. Yeah, so thank you for watching, and next I will keep updating. So next I'll be dealing with 5 markers and 2 markers. So that's all for today. Thank you. Subscribe to my channel.